Welcome, global health changemakers, to Europe's most influential digital health conference, HIMSS and Health 2.0. You have the power to embrace disruptive innovation, to harness the power of information and technology, to realize the full health potential of every human, everywhere. How will you be the change? Let's reimagine health together as one HIMSS and one world. Together.
Hello everyone, and welcome to HIMSS and Health 2.0 Europe Digital. Thank you for joining our session titled Critical Care in Critical Settings, Lessons Learned from COVID-19, and focusing on a crucial topic, supporting and protecting the front line. Please remember that you can join the conversation via Twitter using the hashtag HIMSSEurope20. And without further ado, please welcome our moderator, Dr. Ana Rafaela Prado, Chief Clinical Information Officer at the Lusíadas Saúde Hospital in Cascais, Portugal.
Hello everyone, welcome. I'm very grateful and excited to be part of this session with such a topic that's so hot and so close to home. I am a practicing physician in internal medicine. I work in the emergency department and the inpatient ward, and I'm also CMIO of Cascais Hospital and CCIO of Lusíadas Saúde. It's a pleasure to be here, like I said, and I'm sure that our audience is familiar with many, if not all, of the speakers today, but I will ask them to introduce themselves quickly, and I'll go around starting with Sarah. Sarah?
Good afternoon. My name is Sarah Newcomb. I am the Chief Nursing Information Officer at Great Ormond Street Children's Hospital. I've been working in the NHS for the last 25 plus years, and 23 of those have been spent at Great Ormond Street. So I'm pleased to be here with you this afternoon.
Thank you. Catherine?
Good afternoon. My name's Catherine Peters. I'm a consultant endocrinologist, pediatric endocrinologist by background, and I'm also a medical information officer at Great Ormond Street Hospital. I've been working very closely with Sarah, so this is why we feel it's appropriate to sit together in the room.
Thank you. Jan?
Good afternoon. I am Jan Kimpen. I am the Chief Medical Officer at Philips, and I am in this role since 5 years. Before, I was working as a pediatrician and as a CEO of the University Medical Center in Utrecht.
Thank you. Maurizio?
Hello, everyone. I'm Maurizio Cecconi. I'm the head of anesthesia and intensive care at Humanitas Research Hospital and Humanitas University in Milan. I'm also the president-elect of the European Society of Intensive Care Medicine. Before coming to Milan, I worked in the NHS as a consultant for 14 years.
Thank you very much. I'll just start quickly by speaking about my own experience with COVID. In Portugal, we're a country with around 10.25 million people, and we had, like most of Europe, we had the first peak of COVID in late March, early April, and we've been going down and with steady numbers since then. I think it's safe to say that the mainstay of support, at least from my experience, has definitely been technology-based. It's such a comfort to be able to share information with other colleagues, and not only nationally but internationally. We were fortunate enough to be able to learn a lot from other countries that had let's say the tidal wave before we did, such as Italy with Maurizio and his colleagues, and with our Spanish colleagues as well. And so this feeling that you're not alone, and this is totally technology enabled, really I think was a big comfort in an unknown setting that nobody really was ready or prepared for. And it leaves us a little bit less anxious than the first time, knowing that we will probably have a second wave now in the winter. But it gives me a lot of comfort to know that, again, in this new battle that we're getting ready for, we have collaborators, and we have colleagues that we can easily get in touch with, and we have other types of technology that will enable us to keep in touch with patients inside the hospital, but also outside the hospital. So without further ado, I will pass my word on to Sarah and Catherine from Great Ormond Street Hospital. Thank you.
Thank you. We have the first slide, please. So Catherine and I are going to talk to you today a little bit about our experience at Great Ormond Street, which is different to the experience that many of our colleagues across London have seen. So in the next slide, I'd just like to introduce you a little bit to Great Ormond Street, first of all. The Great Ormond Street Children's Hospital was opened in 1852, and we are a tertiary and quaternary paediatric referral centre. We have a very large research and teaching hospital, and we have a lot of research ongoing at the moment. We like to think of ourselves as a small but mighty organisation. We see around 240,000 outpatient appointments per year and about 43,000 inpatients. Of those inpatients, around 50% of them are under the age of 3 years, and many of them are complex patients who see multiple specialities. We have around 400 beds, and to staff those beds, we have around 4,500 staff. When we went live with our EPR in April 2019, we saw our organisation move to a paperless way of working, and this has allowed us to manage the pandemic in ways that we thought would be impossible beforehand. I'm going to talk to you a little bit on the next slide around the inpatient side of things. So from an inpatient perspective, we knew that the pandemic was huge and that our adult colleagues were under extreme pressures in all of the organisations across London. We didn't see the same scale of intensive care patients within paediatrics. We sent nurses from our organisation to support our colleagues in other organisations, and then we designed a way of creating space at Great Ormond Street. So we closed all the North Central London paediatric services so that we could then house the children in Great Ormond Street, so that those areas could be made available for the adult population who were suffering with COVID. In order to create the space, we were lucky enough that our larger adult facility close by to us used the same EPR system that we did. So we were allowed to share notes between the two different sites, which gave us great visibility of these patients. We didn't know at the beginning how COVID-19 would affect the paediatric population, so we staffed up to 85 intensive care beds, and we didn't see anything like that sort of scale. We did have patients admitted into the organisation with late presentations of symptoms. So, for example, children with DKA were presenting into intensive care because they were not seen early enough due to the pandemic. We spent lots of time building reports so that we could have great visibility of our patients, so that we could see not only what the status of our patients were, but also their parents, so the people that are with them most. And we spent a lot of time on dashboards looking at where our areas of most COVID positive patients were. We moved many of our team meetings and operational meetings onto our Epic platform so that people could communicate around the patients without actually being in the ward areas. And that provided us with a sort of multidisciplinary team approach, but not creating a huge space for staff on the wards. Several of our services moved to remote working and are still in fact doing that to this day. And that is really around our dietetics type of team. Catherine will now talk to you a little bit on the next slide around the outpatient activity.
Yes, so whilst we were configuring things from an inpatient service, we have a very large outpatient service, and we needed to find ways to see those patients. We have a patient portal which had gone live at the time we went live with our EPR, and at the start of the pandemic we had 10,000 patients signed up. We were ready to go live with a video visit consultation type within that patient portal, but we hadn't done so at the time of the pandemic starting. But we were able within 2 weeks to bring in a third party and integrate in telemedicine into our EPR. So we were able to really quickly leverage the power of video visits in an integrated EPR and to see our patients through video visits and online. So that meant that our patient portal uptake massively increased. We now have over 26,000 patients on the patient portal, and it meant that we were able to, although the face-to-face visits fell from 15,000 a month to 2,000 a month, our telemedicine appointments went from 1,000 a month to 10,000 a month. So we did a massive, rapid reversal. And we were also able to see multiple team members on those same video visits. So that was a great advantage to us, particularly as we had a lot of staff who were shielding or were having to self-isolate, and they were able to carry on and take part in the outpatient activity, whilst other doctors were able to remain in the hospital and carry on the inpatient activity. Next slide, please. Just to highlight the difference between the paediatric and the adult population, the UK government issued a list of vulnerabilities and advised patients with those vulnerabilities to stay at home. But we couldn't see how that really fitted in with our paediatric population. And when we looked at that list of vulnerabilities, 50% of our background GOS population actually fitted into those vulnerable categories. And although they haven't come out well in the slides, the colours on the far left are the different vulnerable categories and where our patients fitted. And in the slide next to it are the patients who we saw who had COVID-19. And the only colour block that has slightly increased is the navy blue one, which is the children who are having active chemotherapy and most likely immunosuppressed, but as in neutropenic and very poor blood films. But the other children who had all manner of immunosuppression and other illnesses did not seem to be at increased risk. And when we look at the far graph, that is our patients who were admitted with COVID. And one colour represents those that were vulnerable and the other colour represents those that weren't. And we didn't see a difference between the two. So I think what we're really trying to highlight is the paediatric population and the paediatric experience is very different to that of the adult experience. We've managed to leverage a lot of technology to help us to continue to function as much as possible as in terms of activity and to keep our patients safe. But we haven't seen the level of intensive care and sick patients that our adult colleagues did. Thank you.
Thank you very much. We can go on to the next presentation now, which will be Maurizio.
Hello, everyone. Thank you for giving me the opportunity to share my experience that I would like to say it's our experience from Milan, because probably one of the most important things that happened during the very first hours was the fact that we realized that to face this unprecedented crisis, we could always work as a network to try to share as many resources and as much knowledge as possible. Next slide, please. And for the ones of you that may remember, indeed, this is how our story started. It was really February 2020. A patient on his 30s admitted to the intensive care unit in Codogno Hospital, Lodi, Lombardy, Italy, tested positive for a new coronavirus. For us, that was really waking up with kind of a nightmare, because up to that moment, we thought that we had a situation under control. This patient, however, didn't have any risk factors at all for having been in contact with a previous SARS-CoV-2 patients. And indeed, we never found who was the contact that gave the coronavirus to this patient. So one single patient, one single point of data was enough to trigger an emergency response immediately, because we realized we probably have a secondary transmission, and probably we had a secondary transmission unrecognized for a few weeks, maybe months, and now data suggests that indeed probably the virus had been circulating for a while. Next slide, please. Data and technology was very important from us for the very beginning. Even with the surprise of what was happening, we started to collect data immediately with the Lombardy ICU network, and we were collecting sometimes very simple data, but in a very methodical way, just the number of patients that were positive and admitted to the intensive care units of the network. And it allowed us to model this with the Foundation Bruno Kessler from Trento with Professor Merler, and this was a paper that we published with Giacomo Grasselli and Antonio Pesenti, a viewpoint, together with an interview that I held in JAMA to try to share as much as we learned in the first 2 weeks of this cluster in Milan. And as you see here, mathematical modelings, they are always as good as the data that you feed into it, and of course they have a lot of uncertainty. But we had two models here. One that would have been a linear growth. Still, that would have been a lot to take on for the number of ICU beds that we had initially to start with. And an exponential model without control of the cluster in the community, it would have meant almost 14,000 admissions to the intensive care within the next 2 weeks. It's a model. We don't know if that would have been true or not, but we didn't want to take risks really to go any closer to that. That's when the region and the whole country was put in a lockdown, the first big lockdown that happened worldwide. We think it was a very difficult decision, but probably a very responsible decision to protect Italian citizens, but I would say also to protect other citizens. Next slide, please. So you can imagine there was a lot of uncertainty during these days. When you have uncertainty, sometimes you want to wait for more data to make sure that what you're saying is true or not. However, when you are faced with an unprecedented situation, I also think that good leadership is taking the risk of disseminating the data as good as it can be. And that's indeed after 10 days from seeing patients coming to our intensive care unit with a speed and a rate that we've never seen before, we decided together with the colleagues of the network to reach out to the European Society of Intensive Care Medicine, for which I'm the president-elect. I called the president, Joseph Keseshoglu, and basically said, look, what is happening here? It's something that we were not prepared to face. We think we have the duty to communicate this because in case something like this occurs in other cities, in other countries worldwide, we need to give precious time for people to prepare. And you may see that this letter went around the world through ESICM. It was picked up by several countries. Probably some of the key messages, they still hold the truth there. I really think that this crisis is not just something that you can win just in intensive care by increasing beds. It's really about trying to control the transmission of the virus as much as possible. It's not just about ventilators, it's about how do you increase competencies in a short period of time so that we have enough people able to use those ventilators in case there is a second surge. Next slide, I've almost finished, and just to show you some pictures from my intensive care unit. This was the first intensive care that we opened within 24 hours of the emergency in the region, with the first positive case of secondary transmission. In order to protect my staff, I decided to go for a higher level of protection than what was initially recommended. Again, because there was uncertainty in the data, and I thought we cannot take the risk to go below what maybe could be necessary. So this is a picture of a safety officer. It was basically someone that we decided to have to try to help with the donning and doffing procedure in order for people not to make mistakes. And I would say, again, technology helped a lot with simulation. The first 48 hours, we use an in-situ simulation team to teach people random drills, to work with gear that we never used before in a crisis like this, to create new intensive care beds. And this model we then replicated for the next 6 weeks. Every time we have to modularly increase the number of beds we always wanted in a safe way, so that it was safe for our patient, but also safe for our staff. And I have to say that we've probably also been lucky, but this way of working allowed us, at least in my team, to have a very low infection rate, indeed lower than the one that was present in the community at the same time. Thank you.
Thank you very much, Maurizio. Jan, would you like to start?
Yeah, thank you very much, Anna. It is really an honor to be on this panel this afternoon in order to talk a little on how a big company that has been very, very close to the frontline workers already for ages is behaving during a pandemic crisis as we are witnessing now. As a doctor coming 5 years ago into the corporate world, it was very impressive to see how Philips, as a big company, could pivot into helping the front line almost immediately. In the first days of the crisis, we already decided to rally behind what we call the triple duty of care. Serve our customers better with what they need now, take care of the health and safety of our employees, and take care of business continuity, which was not an easy task. So we prioritized very, very fast towards products and solutions that could help frontline workers in coping with this huge inflow of COVID patients. And to give you a few examples, we ramped up the production of medical ventilators 4 times with the development and the construction of a new invasive as well as non-invasive new ventilator within weeks. That would have taken us otherwise maybe a year to develop a new ventilator like this. Since we saw that telehealth was accelerated in all over the world in order to serve more patients and care for more patients, we also accelerated our development of digital tools. We developed a platform to help hospitals share data of COVID patients that went from one hospital to the other. We developed a new triaging application that general practitioners could use to triage their COVID patients. We helped an increase of the ICU capacity by stepping up on remote monitoring solutions, the so-called electronic ICU, where we do the monitoring and the reading of the patients and their data remote from the bedside. We developed a biosensor technology as well as a partnership with a biosensor company in order to connect that biosensor to an application that could monitor and measure patients at home. And we developed also a diagnostic algorithm for triage of CT scans of patients with COVID. That are just a few examples to prove to you how even a big company can pivot immediately to something to deliver products and to deliver solutions that are really enabling frontline healthcare professionals to do their work better, even in these trying circumstances. And lastly, as we will talk about later in this webinar, we did an extra edition of the Future Health Index, where we tried to find out how young healthcare professionals were behaving, but also feeling themselves happy or not happy in the healthcare environment that was tested now by a large number of COVID patients. But we will talk about that later in this webinar. Over back to you, Anna.
Thank you very much, Jan. So now we're going to have a panel discussion followed by questions and answers from the public, from the audience. So if anyone in the audience would like to send in questions, please feel free to do so, and we will answer them at the end. And so I'd like to begin by asking Sarah and Catherine, do you feel that technology will continue to play a part in the second COVID wave in your hospital if it happens? And do you have any plans for this specifically in your hospital, especially since winter is coming?
Yes, thank you. And I think we definitely will have to use technology going forward. You know, it's certainly enhanced what we've done to date. One of the ways that we're going to be doing that is by the use of the dashboard, so we can really monitor exactly what's happening with our patient, staff and family group. I think it's quite interesting that the government guidelines are changing on a weekly basis, so we have to change our ways to accommodate all of that. For instance, this week we're now having to test our bone marrow transplant nurses on a fortnightly basis for COVID to make sure that they are negative before testing those patients that we now know are the most vulnerable. And I think the other thing is the video visits that Catherine talked about.
Yeah, so for our inpatients, the data that we learnt about vulnerabilities has meant that because our patients are cared for in very specialised wards, that rather than separate them out into COVID wards, we are keeping them on the wards where they have the nursing and the doctor expertise, obviously within cubicles, but they get the specialist expertise they need. And that has pushed us to look at developing inpatient video visits to minimise the number of people going in and out of rooms. So that's where we're heading for our next step in technology for our inpatients.
Right, thank you very much. I have a question for you, Jan. What have been the major learnings that you've garnered from global operations of Philips during this pandemic, and how have these been applied to support the clinicians? So what surprised you more about the response of the younger clinical workforce to COVID-19?
I think that's a very good question. If we want to look at the workforce of the future, that are the young doctors, and these pandemics give us the opportunity to ask them how they would see their life in the future and their life when a big pandemic like this hits them. And what we did in the beginning of the year, we did already a big survey of young healthcare professionals to see how their education was preparing them for the work that they were doing, how they were looking at digital technology, and how they were looking at their own working environment. And then COVID hit us. So we decided during this COVID crisis to go back to 500 of these 3,000 young doctors and young nurses in China, France, Germany, Singapore, and the United States. And we tried to dive deeper a little bit on how this COVID crisis had influenced their original responses. Now, what we saw was, and I'm going to summarize the data very briefly because tomorrow we will launch the data in their completeness to the world. And what we first found was that the commitment to their career seems to be higher than before COVID. There were 38% of young doctors told us that this crisis made them feel more passionate to stay on in their profession than before. So it incentivized them that they were doing, or it gave them the impression that they were doing something that was really valuable for society and for their patients. They also reported to us, 47%, that there was a greater appreciation from patients during this COVID crisis than before. Then going to the new ways of working, which was the second area that we investigated, these young doctors gave us the message that collaboration also across specialties was much easier during the COVID crisis than before. 44% mentioned that to us. And the second thing in that new ways of working was that they saw a pivotal role of technology. They were already convinced that technology was going to help them doing a better job when we did the first analysis in the beginning of this year, but now they found even more passionate about technology making their life easier. And then the third bullet was on what kind of technology. And when we did the first investigation, the first study in the beginning of the year, the majority of these young doctors were very passionate about AI, artificial intelligence. And now that they had the COVID crisis on their hands, many more found that telehealth was the technology that would help them more, and that went a little bit at the expense of their passion for artificial intelligence. And then they gave us also some critical remarks, and they say, okay, if the digital, we know that technology would help us, we know that telehealth is accelerated and it's really making our lives and the lives of our patients better, but the fact that it is still so difficult to share data, it is still so difficult to take care of interoperability between all the systems, it is still clunky and vis-a-vis what we would expect from a real digital solution that would help us to the max. So that were, in a summary, the readings of the current Future Health Index report. Better collaboration, more respect from the patients, and a definite passion for telehealth and other digital technologies.
Thank you very much, Jan. That sounds really interesting, and be sure not to miss the session tomorrow. I just want to end the panel discussion with a question for Maurizio. As president of the EU Society of Intensive Care Specialists, how do you feel clinicians were supported by real-time sharing and communication of protocols across Europe?
I think that this crisis, despite being something that has really stressed everyone working on the front line, was probably also one of the most unifying moments that we had in terms of clinical and scientific community. I also think that scientific associations like ESICM, we felt that we had the duty not only to connect people, but also to kind of filter the information that was coming through. I've never seen so many drugs, being presented on the media, on the news, like in this pandemic. But despite that, only a few of them being tried properly in trials and so on. So with ESIC, for instance, what we did was from the very first week, we started to open with webinars. They were completely free for everyone, not just for our members. And we started to invite speakers from China, from Italy. We started to do a lot of activities exactly for this, to try to bring people together, to share knowledge, to share information, also to filter some of the information so that clinicians could feel what I'm facing here, it's something that I'm not alone. And maybe what I'm learning on one side, I can share with others so that my experience can actually help other patients worldwide. So I have to say, from that point of view, I believe it was a positive moment from the scientific community and the clinical community. And I really think we have to learn from this and not forget about this when the crisis, hopefully at some point and hopefully not too far away from now, will finish.
Thank you, Maurizio. So we have a lot of questions coming in from the public. We'll try to answer as many as we can. There are a couple here about telehealth, and I'd like Maurizio and maybe Sarah or Catherine to comment. One of them is, many countries are reporting decline in use of telehealth services as things are settling down and patients tend to go back to the old way of doing things, Italy included, as per the HIMSS Italian community webinar last week. How can we make sure progress is not reversed and that the workforce and the citizens are equipped to continue and embrace this wave of transformation? So Maurizio, what's your take on this?
I think, very often we say, from Latin, it's in medio virtus, which means, we have to go in the middle sometimes to find the truth. I believe that telehealth and telemedicine has been instrumental for this crisis to try to get in contact with patients, but also, we use also sometimes just video system to link one new intensive care unit to expertise on the other side of the hospital, maybe. So it's really trying to, to bring telemedicine even with tools like Skype or like any other, voice over internet platform that allowed us to connect with people. It has also been clearly very important not to forget all the other patients that were non-COVID patients that we had to take care of. But at the same time, I would say it's great to use this technology, but probably if the situation goes under control, there is also important not to forget that, some part of our job requires some being physically closer sometimes to our patients. So I guess we have to find the right balance so that we use the technology to minimize the risk of transmission in the community and therefore to limit this, but at the same time, not to be worried to see whether maybe we can go back to some so-called old way of doing stuff. I call that the doctor-patient relationship, and even for that is important.
Yeah, I agree. Sarah and Catherine, I wonder what's your take on this, if you think that we will go back, and if because you mentioned you have your telehealth component of the outpatient clinic, especially including multidisciplinary telehealth consultations, which was really interesting. I wonder if there's still paper that's involved in this new way of consultation, and if you learned anything from this.
So we're completely paperless. All our orders are paperless, so X-rays, blood tests, etc. What we've found is that in order to leverage telemedicine, it needs to be of an advantage to the patient and to the clinician, because you need the clinician buy-in. So a lot of the positives that have come out of it is that our patients travel a really long way, and actually the savings in cost and time, especially coming into central London, have actually meant that a lot of our patients prefer the video visits. Obviously, the clinicians then have to make a decision as to whether it's appropriate or whether they need to examine the patient. We have a group that's looking at our video visits to see if we can make sure that we're offering an equitable service, that we don't miss groups, who don't have access to the technology, that we've covered off the safeguarding and the governance aspects, and actually some really practical stuff, like our clinicians who are at home. Do they have the right chairs and the right monitors and the right hardware and the right desks? And these are boring things, but when it comes to doing technology from home and doing it effectively, we actually need to look after our workforce and to do that properly.
And
Thank you very much.
As a safeguarding element, really, I think certainly from a paediatric perspective, you know, we do need some governance around virtual technology. I think we have seen an increase in safeguarding issues across London during the pandemic. So it's things like we need to have cameras on when we're seeing children so we can actually visualize the home environment and what these children look like. Because obviously when you're seeing them in clinic, you can see that face to face. Are there bruises? Are there any concerns around that family? So for me, there's definitely a piece around that for us to continue working with.
Yes, that's very important, especially in the pediatric, maybe also in the elderly population. That's a very interesting perspective. Sorry, we're running out of time. I'd just like, Jan, if you could just give a short answer to this question. Someone asks, there is a session tomorrow about clinicians' burnout, and what is the best way to support and protect the mental wellness of our frontline? Did you get any insight of this from the Future Health Index?
Yes, besides the digital revolution that we all have to embrace, these young people, they want a flexible workplace, a flexible work environment where there is room for own input in their own work, and they are looking for a collaboration in their environment. They want more collaboration, they want more flexibility, they want to be part of the decision making, and they would like to work in what we call a smart hospital, where the human factor is seamlessly interacting with the digital factor in their workflows. That are the three most important messages they gave us.
Okay, thank you very much. Well, thank you very much to everyone. I'm sorry we didn't get to answer all the questions for all the people who contributed with such interesting questions. I'm sure they will be answered, and there will be a chance to go to be answered in other sessions. And so I'd really like to thank this elite group of panelists who were so wonderful, and for your generosity in being here and sharing all your experience with us, and for having allowed us to learn such valuable lessons. And so I'd also like to thank all healthcare professionals for continuing to fight in the front lines. And so thank you very much. This is a wrap up. Thank you.
A big thank you to our Changemaker sponsor, Philips, for their incredible support of our first critical care session. For more information on their product and services, please visit the Philips exhibition booth. We'd also like to take this opportunity to thank all our frontline workers working tirelessly to battle this pandemic. We now have about 25 minutes for you to explore our virtual environment, including the exhibit hall. Visit the hall to learn more about the solutions which best fit the needs of your organization. We'll see you back here at 4 p.m. CET for our third and final session on critical care in critical settings, preparing for the next wave, where experts will share evidence-based learnings from the first phase of the pandemic with the goal to support preparations for future spikes of this devastating virus. We look forward to tuning in with you. We'll meet you back here at 4 p.m. CET. Enjoy the break.